Hello. This video covers how to do a tracheal intubation. Normally, you do everything on this list, but to keep things concise, this video will focus on the steps in blue, and will also cover special populations like infants and children, frequently asked questions, and include a summary. As a word of caution, we're not covering every possible type of equipment on the market. Make sure you understand how your own equipment works and how it may affect your procedure. Your institution may have different strategies for intubation than the ones we cover here. Be sure to follow your institution's policies.
Here's the equipment you'll need: a bag mask ventilator, oxygen, pulse oximeter, suction, a laryngoscope, a bunch of laryngoscope blades, multiple endotracheal tubes of different sizes, stylets for the endotracheal tube, which are also called a tracheal tube inducer, an end-tidal CO2 detector, a 10 milliliter syringe to inflate the ET tube cuff, a laryngeal mask, a cricothyrotomy set, oral and nasal airways, pharmaceutical drugs, sterile lubricant, towels, pillows, bed sheets to position the patient, and tape. A mnemonic we use goes like this: forgetting just one of these items during intubation will make you feel lost. First, pre-oxygenate Fred with 100% oxygen to give us more time for intubation before he becomes hypoxic. To effectively pre-oxygenate, we will also need to ventilate. This will fill his lungs with oxygen and flush the nitrogen out of his lungs to create a reservoir during apnea. Adjust the patient so that their head and shoulders are at a 25-degree angle to the bed. Place nasal cannula in their nose and set the flow rate to 6 liters per minute, or the highest that's comfortable for them. If the patient is breathing on their own, have them wear any face mask that's available. Set the oxygen flow rate between 5 to 15 liters per minute. If the patient's responsive, have them completely exhale, then take a deep breath in, followed by 5 minutes of normal breathing. If the patient is unable to breathe on their own, use a bag valve mask. Check to make sure all of your equipment works. Check if the laryngoscope light is working. Inflate the cuff of the ET tube to look for leaks, then deflate in preparation for laryngoscopy. Now, insert a stylet through the ET tube to make it stiffer during insertion, but stop the stylet before it reaches the end of the ET tube. We never want it in front of the tube's tip. Bend the section of the tube after the cuff, leaving the remainder of the tube straight. Lubricate the tip and cuff with sterile lubricant. Now, elevate Fred's head with a pillow and tilt the head back far enough so that if 2 pencils were sticking out of the nose, they'd be balanced almost perpendicular with the floor. Another quick way to check if you're in the right position is the patient's ear should be in line with their sternal notch. This is called the sniffing position and is identical to the position used when opening an airway using the head tilt chin lift method. Adjust the height of Fred's bed so that Fred's head is just below your sternum. A quick note, most laryngoscope blades are made for right-handed people. If you're left-handed, you still need to follow these same steps. Sorry. Okay, hold the laryngoscope in your left hand with the base of the blade partially in the palm of your hand. Let your pinky finger wrap around the base of the blade. Scissor open Fred's mouth with your right hand. You can do this by placing your thumb on the lower molars and your index finger on the upper molars and pushing against the respective teeth with both fingers to crank the mouth open. Insert the laryngoscope into the side of Fred's mouth closest to your right hand. Staying on that side of the mouth, slide the blade forwards, pushing the tongue away and to the left. Staying on one side of the tongue is important. It helps you control the tongue and see the vocal cords, and also avoids causing trauma to the tongue during the following steps. Now, slide the laryngoscope blade towards the tongue base while lifting the laryngoscope in the direction the handle is facing, which is towards the ceiling and slightly forwards. Continue until you can see the epiglottis. If you need to, have someone pull Fred's cheeks back to help you visualize these structures. Several adjustments might need to be made in order to properly see these structures, but that's why you pre-oxygenated. At this point, if you're using a curved laryngoscope blade, insert the blade tip into the space between the base of the tongue and the epiglottis, known as the vallicula. By applying upwards pressure here, we pull on the hypoepiglottic ligament, which in turn pulls on the epiglottis, revealing the vocal cords. Watch how the epiglottis reacts. Then readjust the blade forward by nudging it just a couple millimeters, applying upwards pressure again, and then see how the epiglottis reacts. This technique is called spooning. If the epiglottis is slow to open, you need to advance the blade forwards. If the epiglottis moves in the opposite direction, your blade is too far forward, or it's at an angle that is too steep. If the epiglottis twists sideways, you need to move the blade more midline. Keep spooning until you find the best spot. Ideally, the epiglottis should move quickly upwards, allowing you to see the vocal cords. When lifting the laryngoscope, keep your arms in to reduce fatigue. Always lift up at a 45-degree angle to the floor and never use the laryngoscope as a lever. This is really important. Doing this can crack, chip, or even dislodge teeth. Avoid pressure on the teeth during intubation at all times. Okay, so we've talked about how to insert a curved blade laryngoscope. If you're using a straight laryngoscope blade, the insertion of the laryngoscope is the same. Where it differs is when the blade is just outside the epiglottis. At this point, you want to slip the blade ever so slightly under the epiglottis and pull it upwards until you see the vocal cords. Don't push the blade too far under the epiglottis. You might move more than just the epiglottis, making it hard to view the vocal cords. At this point, the technique is the same for both curved and straight blades. Once you see the vocal cords, keep your eyes locked on them and never let anything obstruct your view of them. And this is really important. Have an assistant hand you the ET tube. Using your right hand, insert the ET tube along the cheek closest to your right hand. Don't let the ET tube obstruct your view of the vocal cords. Advance the tube until the tube cuff passes through the vocal cords and the tube enters the trachea. Then advance the tube another 3 to 4 centimeters. Once the ET tube is inserted, remove the stylet and have an assistant attach a bag valve mask to the ET tube with a CO2 monitor connected. Bag the patient a few times and make sure that the ET CO2 is detected. If this is the case, you can be confident that the ET tube has been inserted into the trachea. Additionally, you can look for fogging in the ET tube during exhalation, or bilateral chest rise during inhalation. We want the end tip of the ET tube to be around 3 to 7 centimeters, or about 1 to 3 inches above the carina, when the head is in a neutral position. In most men, the ET tube should read 23 centimeters at the upper incisors. In most women, the ET tube should read 21 centimeters at the upper incisors. Tall people might need a bit more tube, and short people might need a bit less. If a cuffed tube is used, inflate the cuff to a pressure between 20 and 25 millimeters of mercury, which is around 5 to 8 milliliters of air. During emergencies, inflate the cuff to 10 milliliters of air and adjust as soon as possible afterwards. Prolonged overinflation of the cuff can impair capillary circulation in the trachea, which can lead to ischemia. Auscultate the posterior lateral chest, not the anterior chest, and listen for breath sounds. Breath sounds should be heard in both the lungs. Readjust the tube if breath sounds can only be heard in one of the lungs. And breath sounds shouldn't be heard in the abdomen. If a consistent waveform is acquired with the end-tidal CO2 monitor, and equal breath sounds can be heard in the lungs, these further add evidence that the ET tube has been positioned correctly. Congratulations. Okay, and now for arguably the hardest part, securing the ET tube. To secure the tube, move the ET tube to the corner of the mouth. Then place 2 tongue depressors on one end of a long stretch of tape, and fold the tape over them once. Feed the tape under the neck of the patient, grabbing the tongue depressors on the other side. Now unwrap the tongue depressors and discard them. Split the tape down the middle for about a foot, then temporarily affix the tape ends to the pillow. Okay, when you're ready, take one of those split tape ends and begin sticking it up on the side of the cheek, wrapping the remainder of the tape tightly around the ET tube. Now, take the unsplit tape end on the other side of the patient and split it in half too. With the top split end, secure it across the patient's cheek, upper lip, and down the other cheek on top of the tape that's already there. Shorten the tape if you have to, and fold the tip of the end piece on top of itself, just to make removal a bit easier later on. Alright, we're almost done. Grab the other split tape end from the same side and secure it just like you did a moment ago, but instead of securing down the other cheek, wrap the end around the ET tube, over top of the tape that's already there. Now, with the last remaining split end, secure it across the two cheeks and the top lip. Finally, take one new piece of tape and put it across all your handiwork, cheek to cheek. Nice work! The tube is now secure. Alright, so now order an X-ray to confirm placement. The tip of the ET tube should be between the 3rd and 4th thoracic vertebrae, about 3 to 4 centimeters above the carina. Infants and children have smaller residual lung capacities and will become hypoxic faster than adults, giving you less time to intubate. Children lying supine are often naturally in the correct position for intubation. A towel under their shoulders may be the only positioning that you need to do. A child's muscle tone is also weaker than an adult's, so an assistant may need to hold the child's head during intubation. Measuring the tube placement is also a bit harder with children. The calculation to figure out tube depth is the child's age in years divided by 2 plus 12. So if we had a 5-year-old, it would be 5 divided by 2 plus 12, and the depth would be 14.5 centimeters at the upper incisors. Alright, so this is a complicated procedure, so let's look at some potential troubleshooting options. Obese patients need more head elevation than normal to position the airway. Place blankets, towels, pillows, or a special ramp device under the head, neck, and shoulders. We need to ensure that the ear is in line with the sternum. Laryngospasms are contraction of the vocal cord adductor muscles and occur more often in children. Laryngospasms narrow the opening to the trachea. Never, ever, try to forcibly push the ET tube through the vocal cords. Often, a laryngospasm has a short duration, followed by a brief relaxation phase coupled with a gasp from the patient before another spasm occurs. Advance the ET tube during the gasp if possible. Solutions to laryngospasms include applying lidocaine spray to the vocal cords. If that doesn't break the spasm, have an assistant push the patient's jaw forward, just like the jaw thrust method for opening an airway. With children, an abdominal thrust, similar to the technique used in airway obstruction, may also provide a brief window for insertion. If none of these methods break the laryngospasms, the next option is to use a paralytic drug and an IV anesthetic induction agent, such as propofol. Regardless of what blade type you use, if you insert the blade too far, you might have difficulties viewing the vocal cords. If this happens, withdraw the blade a bit to allow the airway to return to normal, and then try again. A tracheal tube inducer is a great tool when it's difficult to see the vocal cords, or if you're having troubles intubating. If you can see both the epiglottis and the arytenoid cartilage, place the inducer's tip just below or anterior to the arytenoid cartilage. If the introducer advances in this area and it slides in easily, you can be confident the introducer has entered the airway. If you're having troubles advancing the introducer after it's passed through the vocal cords, it might be stuck on the tracheal wall. Pull back slightly on the introducer and rotate it 90 degrees clockwise to reposition the introducer's tip. If you can only see the epiglottis when using the laryngoscope, make a 60-degree bend near the distal end of the tube introducer. Then insert the introducer anterior to the epiglottis. You can confirm the introducer is in the airway if clicks can be felt on the introducer as it passes over the tracheal rings. If you're still not confident of placement, advance the introducer forward 40 centimeters. You should then feel resistance as you hit the main bronchus. If you don't feel resistance at that depth, you're in the esophagus. Once you've confirmed the introducer is in the right place, have an assistant slide the ET tube over the introducer. To avoid snagging the ET tube on the arytenoid cartilage, rotate the ET tube counterclockwise so that the bevel is facing posteriorly and advance it forward. If you're having troubles passing the ET tube near the vocal cords, you've probably hit the arytenoid cartilage. Withdraw the ET tube slightly and try again using the rotation technique. At this point, you can remove the laryngoscope and ensure the tube is placed correctly. After that, remove the introducer and secure the ET tube. If you accidentally insert the ET tube into the esophagus, remove it, reoxygenate the patient, and try again. When removing the ET tube in the esophagus, be ready for the patient to vomit. Use cricoid pressure during removal and have suction ready. Here are some frequently asked questions about tracheal intubation. When would I not use direct laryngoscopy? Direct laryngoscopy is not the best option if the patient isn't able to open their mouth wide, if you can't see the epiglottis, if there's a lot of trauma or secretions in the airway, if there is significant upper airway swelling, or if the patient has significant kyphosis. What ET tube size should I use? Generally, 7.5 mm sized ET tube sizes are sufficient for all adults receiving orotracheal intubation, but adult men typically receive tubes 7.5 mm to 9 mm in diameter, and women can receive 7 mm to 8 mm in diameter. Nasotracheal intubation may require 6.5 to 7 mm tubes. The larger the tube, the easier it is for the person to breathe through, as tube resistance decreases as the tube's diameter increases. You can almost always adjust the size of the tube later on if necessary, but choosing the right size the first time is recommended. Burn patients may develop swelling in the airways, making intubation difficult later on. Thus, resizing tubes is contraindicated in those cases. ET tube sizes mostly depend on the scenario. Small tubes are fine for short-term anesthesia for operations, but larger tubes are better for long-term intubation and allow for airway suctioning. Intubating children requires a bit more thought. If the child has decreased lung compliance or is likely to remain intubated for a while, cuffed tubes are a much better choice. Otherwise, uncuffed tubes are preferred. You can size an ET tube for a child by matching the tube diameter to the child's fifth fingernail width, or by using the following equations. While there's some guidance on sizing ET tubes for neonates, it's best to decide on a case-by-case basis. Which laryngoscope blade should I use? Ultimately, it's up to your personal preference. Straight blades insert under the epiglottis and lift it upwards, whereas the curved blades insert into the vallecula, putting pressure on the hyoepiglottic ligament, pulling on the epiglottis. A child's larynx can be more difficult to see because it's often closer to the base of the tongue and more anterior in the body. The epiglottis itself is less responsive to pressure applied to the vallecular space. This makes straight blades better suited for children. Straight blades are also better for people with a long, flexible epiglottis, or for people with laryngeal scarring. Straight blades directly move the epiglottis. These blades stimulate the laryngeal nerve and increase the risk of laryngeospasm. Curved blades are better suited for adults, or for people who have prominent upper teeth. Curved blades are also particularly good at preventing the tongue from obstructing the clinician's view, and don't need as much forearm strength to use when compared to the straight blades. These blades indirectly move the epiglottis by applying upwards pressure while in the vallecular space. How long should I spend attempting an intubation? For adults, an intubation attempt can last as long as the SpO2 is above 90%. Once you hit 90%, withdraw, oxygenate the patient again for several minutes, then try again. For infants, an intubation attempt should be limited to about 30 seconds. Can I perform direct laryngoscope intubation on a patient with a spinal injury? Yes, but you cannot elevate the head or place the head into a sniffing position. You can remove the cervical collar and have an assistant immobilize the head during intubation. Why won't the ET tube move forwards after the vocal cords in an infant or child? The narrowest part in the airway in adults is the vocal cords. In children, the narrowest part is the cricoid ring. If you find the ET tube is getting stuck after the vocal cord, try decreasing the size of the ET tube.